next session, and I'd like now to invite Professor Jaroslav Regula to speak about IBS versus diverticular disease.
Thank you very much again. If I can have my slides. So my topic is to give you the overview of the differential diagnosis between irritable bowel syndrome and diverticular disease. I will try to make it shorter because of our lack of time. But I will start with just reminding that irritable bowel syndrome is a functional bowel disorder connected with, the symptoms are connected with defecation and stool consistency, and it is a very frequent disease. Diverticular disease is also very frequent, especially in the aging population, and it has several forms. First, it can be just diverticulosis present without symptoms, or there are other forms where the symptoms, when the symptoms are accompanying a presence of diverticulars. The problem is that both diseases have common symptoms. Namely, in both diseases, bowel habits are changed. Frequently, there is a constipation or diarrhea or mixed. There is abdominal pain, discomfort, abdominal distension, and bloating. And it is sometimes very difficult to distinguish. Another problem is in the diverticular disease itself. If the patient that has just openings in the bowel, diverticular, has symptoms, you never know if these symptoms are related to these present diverticulars or not. Therefore, there are new names, new forms of diverticular disease, and we have to distinguish the situation when there are only present diverticulars with no symptoms. This is just called diverticulosis. From diverticulitis, when you have some form of inflammation, mild, moderate, severe, with or without complications. But there is also between a new form, new disease called symptomatic uncomplicated diverticular disease called SUD, invented by Italians. And this is a situation when you have symptoms and the presence of the diverticular, and it's thought that these symptoms are related to presence of diverticular. And this form, SUDD, mainly resembles very much IBS, irritable bowel syndrome. Not the other forms like diverticulosis, just the presence, or diverticulitis when you have symptoms or complications, but this form of diverticular disease called symptomatic uncomplicated diverticular disease is very, very similar to IBS. And the question is whether this is important or not, whether it matters or not to have the distinct diagnosis. And first, I will give you some data that researchers, mainly from Italy, are trying to distinguish these diseases. And these are the study showing the features that speak more for SUDD or against IBS. So if you have symptoms in the left lower quadrant, the analysis of symptoms suggests that this is just SUDD. The same if the pain is lasting for longer than 24 hours. If the pain is reported as very severe, and if the calprotectin levels are increased. So these all factors speak for the favoring diagnosis of this special form of diverticular disease. Pain location in the lower left quadrant, long-lasting pain, and raised fecal calprotectin. If you are not able to distinguish, which happens quite often, then these features may help you to favor SUDD. And this is the study showing that calprotectin levels are indeed raised in those in whom SUDD was diagnosed, as opposed to IBS-like syndromes where these calprotectin levels are not elevated, at least in this group of patients. So we have some tools to distinguish, although I'm not 100% sure that we are always able to distinguish. Another issue that I want to tell you is the microbiota issue and therapy issue. This is the graph showing different microbiota composition on the level of phylum or on the level of genus. In lower part is the genus. And as you see, the first circle on the left is the normal people, control people. And 3 on the right side, lower and low, are different subpopulations of IBS. And as you can see, a great part of the people with diagnosed IBS have the same microbiota composition as healthy people. It is roughly estimated 1/3 of the people have a normal microbiota composition, having the diagnosis of IBS. And there are 2 other clusters where the microbiota are different, the cluster 1 and 2, with diagnosed IBS, both on the level of phylum and on the level of genus. Also, there are microbiota changes in diverticular disease. On the left, the control group, and on the right, the people with diagnosed diverticular disease. So this is another common feature of both diseases. In both diseases, in majority of people, there are changes in microbiota composition. So the question arises whether we can modulate this microbiota, and maybe we can just diminish the symptoms. So as you can see here in the middle, you can see that we have at least 3 ways to modulate the microbiota composition. This is fibers, these are probiotics, or there is a drug, rifaximin, that is the drug that is only acting in the lumen of the bowel, not going to the blood of the patients, and we can modulate this microbiota both in diverticular disease and in IBS. And these are the studies. This applies for the diverticular disease patients when we treat patients with rifaximin, repeated doses every month, 7 days, 2 times a day, 40 milligrams. As you can see, over several months, the symptoms are disappearing. The same drug was studied in IBS patients with constipation, and the study in New England Journal of Medicine have shown using also much higher dose of rifaximin than for diverticular disease, showed a great improvement with the microbiota modulation using rifaximin. So what I want to say that we can look at both diseases also as the diseases where microbiota play a role, and when we can improve symptoms, diminish symptoms by modulation of microbiota. So in summary, making this talk quite short, I would like to repeat and underline that IBS and diverticular disease in the form of symptomatic uncomplicated diverticular disease, so this is the special form of diverticular disease, have significant overlapping symptoms with similar pathophysiology, with similar laboratory markers, with similar microbiota changes. And maybe the exact differential diagnosis is not really necessary, providing that the treatment using modulation of microbiota is sufficient and the symptoms may diminish. So if I pose the 2 questions, chronic diverticular disease in the form of SUDD or IBS, they are usually very difficult to distinguish. And does it matter for therapy? Usually it matters to know the diagnosis exactly, but in the view of microbiota alterations, it may not matter if the treatment is effective. Nobody, in fact, is really interested what was the diagnosis if it's so difficult to differentiate. The most important thing is the treatment applies. The exact diagnosis would be important for the dosage to be chosen, because in IBS, as studies have shown, the dosage of rifaximin, if chosen for treatment, should be much higher. So thank you very much for your attention. One question, if possible? If I chair, I think we should wait until the end. Yes. Okay, so I would like to ask now Tomica Milosavljevic, another differential diagnosis, differential and management of colon polyps. 10 minutes.
Yeah, thank you very much. My today's task in this afternoon is to keep your attention quickly on reminding on differentiation and management of colonic polyps. And I'd like to point how to see the polyp during endoscopy, of course, about the possibility for differentiation regarding different natures of polyps, and how to choose the right endoscopical approach. And I'd like to start reminding you on Paris classification in the beginning of last decade, defining protruded lesion, flat elevated, and also some adding after Paris classification, which helped us to make this differentiation in a more precise way, including subgrouping in polypoid flat and depressed lesion, and adding granularity. Why it is so important? Because of the science, endoscopical science, with a high risk of invasion. If we have nodular and mixed nature on the surface of sessile lesion, percentage of the risk of invasion is up to 20. But if we have nodular depressed in the middle of the lesion, this percentage is much more higher. And all those tools for differentiation has a great importance for us as endoscopists. Let's be more complicated with Kudo classification of pit patterns of crypts. Why it is so important? Because our machines, our endoscopy views now are more deep and more precise than before. And that is, of course, the explanation why we need this new classification. And there is a possibility now really to see with this high magnification and getting closer to the surface of the polyps to predict histological picture. And magnifying narrowband imaging is absolutely breakthrough in the endoscopy, and we could define now based on the surface view and the pit pattern and some vascular nature, we could see even before removing polyps what would be probable neoplastic lesion. Why it is important to have higher adenoma detection rate? This is almost basic knowledge, almost textbook knowledge now. If you have adenoma detection rate which is higher, then the risk of malignant change of colonic mucosa in interval colonoscopy is significantly lower. And based on the landmark study published first time in New England Journal of Medicine by Jaroslav Regula, Kaminsky, and the colleagues, even prognosis for the patient in screening program are better if you have adenoma detection rate higher. And now there's the classical criteria for higher quality in colonoscopy. Do we have advanced endoscopic imaging today which is really breakthroughs? Yes, we have narrowband as a basic one, but also FICE by Fujinon blue laser imaging, autofluorescence imaging, and confocal laser endoscopy. And that was relatively recently published as a technical report and review in the endoscopy. But when we compare this, the innovation narrowband might be better than standard white light colonoscopy, but equal to high definition white light colonoscopy for detection of colorectal polyps. That was published recently in a Cochrane collaboration review. Then, if you have machine with high definition white light, then your colonoscopy could be effective, almost equal with narrowband. When we compare technological improvement in adenoma detection rate improvement, endoscopic 3-model imaging just reported by Olympus on a commercial basis, combining high definition, autofluorescence, and narrowband imaging is the most promising for the moment. And I just like to show you this fuse colonoscopy with 3 picture. This wide picture during endoscopy is really promising, and in that report by Gralnek a couple of years ago in DDW, this back-to-back colonoscopy comparing with fuse versus standard colonoscope. After initial fuse, adenoma miss rate was only 7, after initial standard 41. But in randomized control trial, this promising regarding fuse endoscopy is a little bit questionable because there is no statistically significant difference in adenoma detection rate if you compare this fuse with 3 picture and the standard high definition endoscope in fecal immune test positive patients. And what is the step forward? Also, there is a novel single-step full-thickness resection device, which is really promising for deep invasive lesions and for the management of even this type of very difficult polyps. Recently, that was published in UEG journal that performance measures for lower GI endoscopy has a crucial importance for the quality improvement all over Europe, and that consists procedural bowel preparation must be in 90% and more effective and good. Cecal intubation rate should be more than 90%. Adenoma detection rate minimum 25 and more. And also very strictly defined rules for pathology, complications, reports, patient experience, and post-procedural appropriate post-polypectomy surveillance. And there is some new entities, including serrated adenoma as absolutely new entity in past 20 years, but those lesions are mostly flat and very difficult to see, and that is the matter of quality. I just like to illustrate some basic issue in polypectomy, as I show you here, just simple elevated with saline and after that snare or cold up to 9 millimeters diameter and more with electrical, with hot, and you see also mucosectomy in action with small lesion and also with bigger serrated adenoma, for example, at mucosectomy in sigmoid colon, but also there is a non-lifting sign, and we decided to do laparoscopic resection, and that was early adenocancer, but R0 resection. And some illustration of not so difficult polypectomies, standard from smaller to very big polyps. And if you see this big one, that is probably inside, of course, probability of malignant change is very high, but R0 resection is possible. And there is an interesting observation. We published last year our polypectomies and colonoscopy regarding malignant changes and adenomatous lesion in 90s and today, and there is a doubling percentage of the lesion adenomatous and malignant in right colon, and that is very similar with the experiences everywhere. And we could discuss about this, why this percentage is doubled in 20 years. Is this only about the better colonoscopy, or perhaps we have some pathological or pathophysiological mechanism here, including microbiota, who knows? And I'd like to show you example from just published in Gut, which is kind of guideline related to large non-peduncular polyps in colon. There is a proposed scoring system to assess polyp difficulty, and that could be very useful in everyday real life. And if we have previous interventions, location in right colon around the ileocecal valve, difficult position or size more than 40 millimeters on previous APC use, that could be independent risk factors for failed endotherapy. And there is a couple of practical directions from that guidelines. First, to photograph or video prior removal, estimate site very carefully, use always Paris classification. Why? To speak the same or the similar language. Describe surface characteristics based on NICE, NBI, or Kudo pit pattern classification. Targeted biopsies only if you have suspicions on malignancy. Do not resect at time of discovery unless you have consent, time, and expertise allow. The optimal scenario for accurate diagnosis is good cleaning of the colon, good characterization with adequate endoscope, minimum high definition white light scope, addition of virtual enhancement techniques only if needed, and depending on the pit pattern and size, choice of adequate resection technique is the crucial. NBI, better than standard, but equal to high definition for detection of polyps. Mucosectomy, safe, and it allows effective removal of the lesions, and block resection by mucosectomy or ESD, depending on the size. It's possible to remove lesion with high suspicion of limited submucosal invasion. And that is the end of my presentation. Thank you.
Thank you very much. And now I would like to ask Professor Kagramanova to speak about screening and surveillance.
So modern screening of colorectal cancer that we're using in our clinic. You know, colorectal cancer is an important issue. It occupies the second place in mortality and the third place in incidence. When we make screening of colorectal cancer, we need to collect anamnesis, given all the potential risk factors that can promote the development of the disease. They are divided to modified risk factor and non-modified. Modified risk factors include the Western food ration. It is low consumption of fibers and a large consumption of protein and easily acquired carbohydrates and obesity. As to non-modified risk factors, these are sporadic cancer, hereditary symptoms, and inflammatory bowel diseases. So inflammatory diseases include ulcerative colitis and Crohn's disease, and it leads to a higher risk of cancer development. Colorectal screening has a lot of recommendations from the American College of Gastroenterology, American Gastroenterology Associations. All these recommendations say that the screening of colorectal cancer is to be done at the age of 50 years in males and females in the absence of symptoms. But each association introduces its own modifications, and there are differences. Speaking about higher risk, such risk factors as family anamnesis, or, for example, family adenomatous polyposis, or hereditary non-polypose colorectal cancer, all these factors place the patient in the group of high risk. And here recommendations about the beginning of screening are different in different associations. Speaking about middle-age people screening, so we have guaiac sample by Weber. This is immunochemical, FIT, so definitions of the DNA of the feces, and invasive methods such as flexible sigmoidoscopy, colonoscopy, erigoscopy, which are done at each 5 years. Speaking about endoscopic methods of diagnostics, colonoscopy is the gold standard in diagnosing colon cancer. It has high specificity and sensitivity, and it reduces the incidence by 31% and mortality by 46%. But it is done only to those groups of the population that have a higher risk of colorectal cancer. 3 strategies have been defined. The first is colonoscopy each 10 years and annual FIT. The second, CT colonography each 5 years. FIT, DNA of the fecus is 3 years. And the third is video capsular endoscopic test each 5 years. That was the last review done by the American Society of Gastroenterology. Speaking about higher risk groups, they include the colorectal cancer or adenomatosis polyp in one of the relatives, or in 2 relatives, or if 2 relatives had colorectal cancer at any age. Colonoscopy is to be done at 40 years in this case, and monitoring of patients is to be conducted each 5 years. If colorectal cancer was detected at the age of 60 in relatives, it is necessary to recommend a screening by the same method as in patients with average risk, but starting from the age of 40. So development of cancer. These are guidelines, screening guidelines on the American Oncological Society. They say that we need to start screening at the age of 45 years in patients of medium risk. And if for patients with the expected life expectancy of more than 10 years, the screening is to be done until the age of 75. And screening is not indicated for patients over 85. As to the recommendations of the American College of Gastroenterologists, they modified their guidelines. They divided methods of screening into methods of prevention and methods of detection. Preference is to be given to the methods of colorectal prevention. Colonoscopy is to be done once in 10 years, starting from the age of 50. So if the patient refuses from colonoscopy, it's necessary to make an immunochemical, fecal immunochemical test. Alternative methods are sigmoidoscopy each 5-10 years or CT colonography each 5 years. As to the high-risk patients of CRC, these are patients who have family adenomatosis polyposis, who have hereditary colorectal cancer, who have Peytz-Jeghers syndrome. Then the patients get into the group of high risk, and monitoring is to be done very carefully. And there are special guidelines to this effect. There is an Amsterdam criterion. It shows how frequently and when monitoring in a higher risk group is to be done. So genetics is very important in colorectal cancer. That's why DNA diagnostics of CRC is very important. And 2015 saw the publication of the results with over 10,000 people where DNA test was assessed. As to inflammatory diseases, so the risk of colorectal cancer is increasing. If the patient has been sick for over 80 years, then the risk increases 5-6 times. And localization of the inflammatory process is very important. In this case, the development of CRC is rising. So European Organization of Crohn's disease made a statement that in case of long ulcer colitis, the risk of CRC development is much higher. Here we need to make screening frequently, and colorectal cancer is to be detected at an earlier stage. So the screening colonoscopy is to be offered to all patients after 8-10 years of the appearance of first symptoms of the colitis. So our objectives for the future: we need to develop standards of quality of each process of screening. The efficacy of screening depends on how quickly we got into this window and managed to detect pre-cancer. It's necessary to develop and introduce new methods that have a higher diagnostic value, low cost, which is also important. And of course, the primary care doctors are to introduce colonoscopy for all patients who apply for medical aid about constipation and anxiety symptoms. Usually anxiety symptoms already testify to the progression of the disease. We need to advocate screening on the national and regional level and to inform the patients accordingly. This is our Moscow Clinical Scientific Center. Each year we make a diagnostic of intestinal diseases and detect a lot of patients with the FIT positive and very often we detect polyps. So it helps us to prevent colorectal cancer in the future. Спасибо большое.
And now time for questions. You were the first, even before the session.
Thank you very much for very nice presentation. And один простой вопрос. Вот здорово, что мы стали говорить о профилактике.
Very simple question. We started speaking about prevention, but is constipation or chronic constipation a risk factor that can be removed and modified, taken into account that everything starts with proctitis, right-sided and total. We know that constipation leads to low-grade inflammation and then to ulcer colitis and Crohn's disease. What do you think? Is it necessary to focus on the fact that chronic constipation is a modified factor of colorectal cancer and start prevention in students at the age of 20 and not at the age of 50? Thank you. Modification of the way of life is possible at the age of 20. Constipation does not lead to inflammatory diseases, but reasons for constipation may be different. That may be maturity disorders and motility disorders, and constipation is not always accompanied by the inflammatory process. And one of the first methods of treatment for constipation is the change of the diet, everyday physical activity, changing way of life. So it is not a factor of risk. It is not a risk factor. No, it is not a risk factor for the development of inflammation. No.
The risk factor for colorectal cancer, although I know you for many years, you are having your idea that it should be taken into account. For some people, it's logic. If you have a constipation, the contact of the substances that may be carcinogenic stay longer in the bowel, but nobody has proven it is the truth. So constipation should be fighted, but because of it is unpleasant, we should have physiological movements and so on, but not as a way to prevent cancer. Yeah. Marcus, yes.
A comment and a question. The comment first. As a student, I had a virology teacher who later received the Nobel Prize, who is Harald Sohausen. And he has a very interesting hypothesis. He walks around the world right now in his 80s, and he says the major risk factor for colorectal cancer is eating meat and drinking milk. And his idea is based on epidemiological data that in countries where there is very low meat consumption, like India, colon cancer rates are much lower than in Western countries, or specifically the US and Argentina, where enormous amounts of meat are eaten. Something that doesn't fit into hypothesis is Mongolia and Peru, because they eat enormous amounts of meat and they don't have colon cancer. And he says, well, this is not the Western cows, this is yuck inbred into these cows. And he can show that from genetic trace that in Mongolia that's certainly true, and it seems so that in Peru also they have bred a lot of yuck to make them mountain capable into this. I think this so far is a very wild hypothesis, and his idea is virus. It's virus in cow's meat and it's virus in milk that causes this, although no one has found these viruses. But to make a long story short, having a vegetarian diet really is a lifestyle factor that reduces your colon cancer risk by about half. My question is to you, Jaroslav. We're doing some microbiota studies right now because we have this wonderful opportunity to look into this Framingham study in Greifswald, which is called the SHIP study. And we have stool samples from over 6,000 probands now and have done the 16S RNA sequencing. We looked into these patients with the question of IBS. And in the first 1,900 some we sequenced, we looked at those who had Rome 3 criteria, because there were some studies out that said, well, IBS, it's a microbiota disease. And we could confirm it at the first glance, but when you correct for all other GI diseases that cause GI symptoms, gallbladder disease, having had gallbladder disease, having had ulcer disease, the effect is gone. So our current status, we published this in Gut last year, is that IBS is not a microbiota disease, although I do concede that what you've shown quite nicely, what we think is IBS is probably 3 or 4 or 5 different diseases that we lump up under IBS, and they may have very different pathogenesis behind it.
Yeah, I agree with you completely. First, to this maybe infectious agent related to colorectal cancer, there are hypotheses as well from other points of view that spread of the cancer. Some epidemiological data suggest that maybe there is some sort of infectious disease, especially also the young age rise in colorectal cancer in United States, in Europe. So there are some signals maybe that there is an infectious agent involved. And also we know that there is a lot of Fusobacterium nucleatum present in the adenomas and in cancer more frequently than in other tissues. So, but there are no final conclusions about that. And as to IBS, of course, IBS is a multifactorial, many aspects, including psychology and motility, and post-infectious pathogenesis, and so on. So, and also we know that microbiota plays roles in so many diseases, including depression and so on. So we are at the beginning of our understanding what microbiota is doing. But, you know, studies show that if you modify microbiota somehow, the symptoms may diminish. You will not completely abolish the symptoms and the disease, but you can sometimes improve at least distension. But it may be much more complicated than we think. We are at the beginning of the way of understanding what microbiota is doing. But obviously it's doing something.
May I have another question to Jaroslav? What is the pharmacological or pathophysiological reason that you should use higher dose of rifaximin in IBS than in diverticular disorder?
No idea. Probably this was the study, and they have chosen the highest dose, and I have no really explanation for that. This is based just on the studies. There is a need of study to comparing two different doses in these diseases. Marcis?
Слышно, да? В рамках дискуссии...
Can you hear me? As long as we are discussing now colorectal cancer screening, we have heard a lot about the methods and a difference between different methods. But I would like to draw your attention that even more meaningful is, besides the choice of method, the organization of the screening process. And because this we see here the most experienced experts in Europe. It's Bojan Tepic from Slovenia, who has one of the largest experience in the world in terms of implementation of screening programs of colorectal cancer for fecal occult blood tests. And Jaroslav is one of the authors of a successful program implemented in Poland. We would like to leverage the knowledge of these two respected experts, because the test itself will never work if we do not take into account that the screening is a program and it should be well organized.
Remark, Marcis, you know how we are operating for almost 10 years, but I would not like to go in a detail because that is a topic of the whole symposia. For several hours we can talk about it. But of course it is important to have organization set in place. First, that you choose the proper endoscopic centers and experienced endoscopists, that you choose the best pathologists that you have, that everything is centralized so that you collect a database, and that you have the reports that are electronically, that are made electronically, so you can surveil the work of everybody in the process. That is very important. First, you must educate everybody, and then you must audit the quality of everybody that works in the program. So, first, I think you need several years of preparation and reimbursement, and to choose the proper centers, to educate them, and then you should start. Not jump in the water before you prepare all the programs, so it's not as easy.
Yeah, I can completely agree, and furthermore, the first step is to evaluate the epidemiology of cancer in a given country, to know what are the causes of death in the different countries. Not all the world are the same, and what are the expected benefits and harms of screening. And in different worlds and regions of the world, different screening projects are in fact in priority. So it means that there is no ideal one program organization. That is, it should be suited to the society, to the possibilities of the given country, and providing it is a massive size of the project of screening. It has to be really very well prepared, as Bojan has said. So it has to be really piloted first, and then implemented with the highest quality control on every step. Yeah, Marcus.
I agree with both of you, and maybe I can add a little. Germany was the first country where the public insurances paid for colorectal cancer screening, and we started in 2003. And there were different phases. Number one was public awareness about this. Number two, we have a very funny system in Germany where the ambulatory care system is completely separate from the hospital system. So screening colonoscopies are strictly not done in hospitals, but are done by ambulatory care physicians, which is separate. Actually not a good idea to have them separate, but that's what we've been doing since 1954. The next phase was that the number of physicians who are eligible to do these screening colonoscopies, which are more lucrative than other colonoscopies, was shrunk immensely by quality control. They have to have a polyp detection rate of over 20%. They have to have a colon withdrawal time. They have to document the sickle valve. And so in Bavaria, for example, this number went from 1,500 doing screening coloscopy to 200. And that raised the quality, and there's an institute, as you suggested, that always does the quality control. And the third step, and this was opportunistic screening. That means there were some private charities that advertised it, and we had a participation rate of those over 50, or for colonoscopy 55, of between 9 and 16%. So you don't catch those you do want to catch. The Netherlands and Scandinavia started on a different footing, and we changed the system last year, now at least to a nationwide screening, in that sense that the insurance company is obliged by law to actively invite every one of their insured, if they're over 50, for the to participate either in the immunological FOBT, which is more expensive and causes some frictions, but that's been financed now, or to go directly to colonoscopy. So everyone over 50 gets a letter, you're eligible and you should do it. Those were different phases, but it took us 15 years to get there.
Okay, other questions or comments? If not, I think it covers the first part of this session, and now we are supposed to have a case presentation and then some sort of roundtable discussion, multidisciplinary team meeting. You are going to...
Thank you very much.
Thank you.
Good afternoon, everybody. Good afternoon, everybody. I have one case for today. This is an old female, 66 years old, with neuroendocrine cancer of the colon. In anamnesis, the patient underwent surgical procedures for gynecology disease. She underwent the resection of the ovarian because she has a cyst of the ovarian. No cancer evidence previously. She has some diseases of the heart and diabetes of the second type. So the patient complained, she said us about the classical carcinoid syndromes. She has a vomiting, she has a diarrhea, she has an increase of heart rate in the evening. And we start to find where is the tumor. So we do the gastroscopy, nothing. We do the colonoscopy, we nothing find in the colon. We do the ultrasound diagnostic of the colon. And of course, we nothing find in this case. So we do the CT scan. According to the CT scan, we didn't find any pathology in the abdominal cavity. So, but according to the serotonin and chromogranin, we find the level of these markers is very, very high. So, and in Russia, we perform sometimes ergoscopy to define the wall of the colon. Maybe we find something, depression somewhere and something else, but nothing we find according to the ergoscopy. And then we do the PET scan with dotted date, with GALI. So, and according to this method, we find a small lesion in the transverse colon. I try to show you.
Just go there.
Yeah. So you can see this small in the colon, transverse colon. And for this round table, the discussion is what to do the next. This is a small lesion in the colon. This is a syndromatic cancer. We couldn't find we couldn't take any material. We don't know about. This is a carcinoid cancer, and we don't have the pathology report about this cancer. So what to do? Start with the surgical procedures. If yes, what kind of surgical procedures? Right hemicolectomy, resection of the transverse colon, extended right hemicolectomy with D2 lymphodissection or D3 lymphodissection. If we go for the surgery procedures, if we didn't find this lesion, it's very, very small, only 2 centimeters. What to do? How we can find this lesion during the surgical procedures? Maybe start with octreotide treatment. And this is my question for this round table for today.
Okay, so everybody is invited. Are you a surgeon or we miss surgeon here, I guess?
No, a specialist of nuclear medicine.
Nuclear medicine, okay.
Да, я бы хотел прокомментировать немного.
Yes, I would like to give you some comments from a nuclear medicine specialist. It looks like, in terms of finding carcinoid of neuroendocrine tumors of various localization, nuclear medicine should be the most interesting method of diagnostics in the recent years all over the world. However, the nuclear problem wishes for better in Russia because we have only a limited number of tests that are only available in Moscow, in St. Petersburg. However, because PET-CT was done in this and labeled with gallium-68, this is the most sophisticated and the most modern contrast which is used in Russia, and this is the only institution in Russia that is can do this test. This is an analog of somatostatin that reveals the receptors on the tumor cells that do express somatostatin receptors. Actually, what we see here, these are some cells that actively express somatostatin receptors. Taking into account her medical history, these are cells of some neuroendocrine tumor. But I wouldn't be sure if we can cure the patient removing these cells, because PET-CT resolution is 4 millimeters. Everything which is below this threshold is invisible, still invisible for PET-CT. And sometimes it happens so that resection in this area helps relieve all the symptoms, but not always so. But I am in favor of octreotide in this case.
You described there was the only area where there was the present neuroendocrine tumor was the transverse colon, or there was somewhere else? Because if patient has carcinoid symptoms, we expect that he will have a liver metastasis, and it should be present there. But could you describe?
Oh yes, yes, I know. It's only in transversum colon.
Yes. According to the CT scan reports and according to the PET scan reports, no lesion in the liver, no lesion in the gastro, no lesion in the duodenum, and only small lesion in the transverse colon.
But did you do a second look colonoscopy
Yes.
after that?
Yeah.
And you didn't see?
No, we didn't see.
Nothing in the
So,
transverse colon?
We do the laparoscopic procedure, first of all. No. First of all, we give the patient actreotide. So the symptoms is gone down. And then we do the laparoscopic procedure. We do the laparoscopy, diagnostic laparoscopy. During this procedure, we didn't find any lesion. Small adhesion in the abdominal cavity. We do the adhesion lesion. So we do the laparoscopic ultrasound diagnostic of the colon. We didn't find any lesion in the colon or mesocolon, fat tissue, nothing. So we do a small incision and we do the hand maneuver. So we try to find by hand something, nothing. So, and after that, we finished our procedures, and 2 weeks ago, we do the patient give us new markers after procedures, and we find that the markers gone down and goes to the normal position. So, but syndromes is still again. It's the syndromes was the same, but not so. But the intensive of this syndrome is gone down, and we nowadays the patients took the actreotide, LAR. So what to do the next? I think 2 months later we do the DOTA date again and try to find what's happened with this lesion in the colon. If we find this lesion, the next question, what to do the next? Still with actreotide therapy, or do the second look procedures and try to find it. During the laparoscopic procedure, we try to find it with indocyanine green, but this method is not very good for detection of this tumor. We didn't find anything. In arterial phase and venous phase, nothing. How to find it? This is a question.
Can I ask some question, because some I didn't get from the Cyrillic. Did he have elevated levels of synaptophysin and chromogranin in the blood?
Only chromogranin and serotonin.
Okay, but nonetheless, that's very indicative of neuroendocrine tumor. We see a few of those, and we usually regard DOTATOC as one of the most sensitive tests to identify them. The last one I saw that's a little related was a small intestinal neuroendocrine tumor, not far from the cecal valve in the terminal ileum, and it was sitting outside the gut with only a small accidentally found lesion inside, but there was no tumor, intraluminal tumor. It was an extraluminal tumor. So, I mean, treatment is always surgery first for all neuroendocrine tumor. They do have a malignant potential, which you can't assess because you don't know what organ it comes from. I would resect that lesion, and I'm not a surgeon. So I think the patient would be cured. However, you have to have a lesion, either something you can feel or something you can intraoperatively see. Could it be that this is related to the small intestine? So intraoperatively, I would put the entire small intestine over the scope and see whether I see it anywhere there or I can touch it. I don't know how sure you are that you can attribute it to the colon rather than the small intestine. Here, it's huge, the lesion.
Yes, but according to the reports, it's only 2 centimeters lesion. During the laparoscopic procedure, we find 2 lymph nodes, paracolic lymph nodes in this area, approximately 1.5 centimeters. We do the dissection of these lymph nodes and do the frozen section of this material, but nothing from the report from the pathologist. And we remove a big part of the fat according to this area. Because the patient have the adhesion in this area, she underwent the procedure, surgical procedure according to the gynecology disease. And in this area, we have a big adhesions and a lot of fat were there. So we remove this area of the fats and nothing in this fat, according to the pathologist investigation. So, if you look at the scan, this lesion is only in colon cancer, in colon lumen. There is no evidence of this, of something pathology in intestine lumen or intestine or somewhere here or somewhere else. So at the sagittal scan, you can see it's here. This is a normal situation because intestine have something inside, but it's not a tumor. This is it's a normal. Our colleague said that it's a normal view of the PET scan. So this is a normal expression.
Well, I guess you have no choice other than to repeat that procedure after a year. It's very expensive. It's very, very expensive. But before she undergoes another operation, that's probably your best bet.
Colonoscopy.
Ну да, действительно, здесь...
Really, either we have to wait until this tumor grows up to the visualizable size. Probably PET will show something then. But I was thinking about neuroendocrine tumors, about their incidence, and remember hypersensualism in newlyborns, when there is a special test to localize to differentiate whether it is local or diffuse form, whether we can remove part of the pancreas and save the child, or we will have to totally remove a pancreas. So this is a kind of a diffuse position of cells that show hyperexpression of this or that hormone. So that's the same situation is here. We don't see any classical tumor substrate that can be tangible. This is just a diffusion of some cells, probably of a neuroendocrine tumor. Probably they are somewhere else, and we need to wait until they manifest themselves. I hope without metastasis. No.
To have the final conclusion, we have just to wait or to repeat the examinations. I agree completely that the mainstay of treatment is the surgical resection of the tumor, if possible to be found. And then we can have histology, we can grade this, we can assess the risk and the further treatment. So if we can't find it, then it's really difficult. And yeah. So do you have any questions or comments from the panel or the audience? If not, I think we finish this session, and I ask for the last session take-home messages, Dimitri Bodin, to finish it off. Thank you.